Clear light, please.
So, good evening, everyone, and welcome to the MSICS, the Surgery for the World session in this International Ophthalmic Conclave from AIOS. At the outset, I would like to thank Dr. Santosh Unawar, sir, for putting up this fantastic program with a wide array of topics. To start off this program today, we have Dr. Jagannath Boramani, both stalwarts in this field of MSICS. I would like to hand over the podium to Dr. Amulya Sahu, sir, to introduce the panelists and speakers for today.
Thank you. I think the AI is our parent body with the highest number of members in the world for giving us this opportunity. Thank you, Dr. Santosh Sonavara, AIOS Dynamic Secretary, for wholeheartedly promoting the cause of MSICS. ISMSICS has grown very fast, promoting the cause of MSICS. It has chapters in 23 countries and all the states of India. Every 2 years, we are having world conferences in India. 6 world conference has been completed in the partnership with all the leading institutions. Example, Arvinda Eye Care System, Visa Eye Care System, Chandigarh, PGI Chandigarh, LB Prasad, and the last one was with All India Institute of Ophthalmic Sciences. 7th will be in Pune, 7th, 17, 18, 19 December 2027. We have divided India into 5 zones. Every 2 years, we conduct zonal conferences. First round of conferences has been over. Second round has already started. As you all know, we have been able to put MSICS in the same level as emulsification with innovation of tech-free surgery. So welcome you all faculties from different parts of the world to this wonderful webinar. Thank you.
Yeah, thank you, sir. I welcome all of you for this wonderful session conducted by AIOC, the International Conclave of All India Institute, All India Ophthalmological Society. First of all, let me thank the office bearers of AIOS for beautifully conducting this for successfully 6th year. We are going to conduct the session on SICS. We are ISMSICS, International Society of Manual Small Incision Cataract Surgeons. And our partner for this session is CMCC, the Mexican Center for Cataract Surgeons. Let me introduce our speakers for today's session. Dr. Hossam Ziada from Al-Azhar University, Cairo, Egypt will be our first speaker. The second speaker is Dr. Gonzalo Urrutia Zara from Chile. He is from Chilean Society of Ophthalmology and Pan-Cornea board member. Dr. Juan Carlos Gines from Associate Professor from National University of Asunción from Paraguay is our third speaker. Dr. Van has joined from US, who is working for Help Me See, the organization for training in simulator. He is also from Mexican Institute of Ophthalmology. Dr. Karamjit Singh is from Punjab, India, who is the head of department in Regional Institute of Ophthalmology, the Government Medical College, Amritsar. Dr. Kadil Jojo Sinolinding is coming from Philippines. He is the Member of Parliament as well as he is Minister of Health, Bangsamoro Autonomous Region, and he is the Chief Ophthalmologist in Deseret Surgimed Hospital and Deseret Ambulatory Referral Center Foundation, Philippines. Our next speaker will be Dr. Miguel Lieto from Igas Moniz Hospital, Lisboa, Portugal. And our last speaker who will be presenting a case, Dr. Miguel will be presenting the case. Our discussions for today, the expert panelists are Dr. Helena Pryor Philip. She is also from Igas Moniz Hospital. She also works in West Lisbon Hospital Center, Portugal. Dr. Pamela Gonzalez Daher is from Mexico. She's from Mexican Institute of Ophthalmology, as well as she is a part of CMCC. Dr. Parikshit Gokte is the Vice Chairman of ISMSICS. He has joined from Pune. He is from Community Eye Care Foundation. He has got his own clinic, Dr. Gokte Eye Clinic, and he is also professor in D.Y. Patil Medical College, Pune. Dr. Neeta Dodwar is the director of Brahma Netralaya, director of Gurneet Foundation. She works also for Prasad Chikitsa. She is our next discussant and she is from Mumbai. Dr. Purvi Bhagat is professor in M&J Western Regional Institute of Ophthalmology, Ahmedabad, India. Dr. Anu Malik is assistant professor from Dr. R.P. Center, All India Institute of Medical Sciences, New Delhi. So with this brief introduction, I would like to invite our first speaker, Dr. Hosam Ziada from Al-Azhar University, Cairo. He will be speaking on when you miss the tool, MSICS can do the job. Dr. Hosam, please. All the speakers kindly restrict your timings.
Hello, good afternoon, Doctor. Good evening in India, Dr. Brahmani, Professor Mulusaho, Dr. Parikshit, Dr. Pamela, and everyone. Thank you so much for inviting me to this prestigious meeting. So I will share my screen now for the sake of time. But please don't count my minutes from now until I am ready. Is my presentation is visible now or not yet?
Yes, sir. Yes, sir.
Okay. When you miss the tool, the MS can do the job or can do the magic and change the map. Actually, the manual small incision cataract surgery is doing the magic in my practice. And I summarized all this experience regarding this technique in this word. Surgery is a handmade art, so we have to drive the machine and not to be slaves for it. Because the physical surgeon who is stuck in any case, he cannot change the map of the surgery, either to abort the fecal emulsification or to convert to the manual small incision cataract surgery. But manual small incision could be a very good alternative, especially if you miss the tool in your OR. Look at this. Look at this rookie heart cataract. I think it's not one of the best choice for the fecal emulsification because the hardness and the very old age. This patient was around 85 years old, with very vulnerable cornea. So it could be a danger procedure to the endothelium if you went for fecal emulsification. So I miss here the patient's suitability, not actually the machine itself, because whatever the machine, it could be insulting to the cornea because of these factors. So here I could deliver the very big nucleus with no obstructed labor or delivery through this 6 mm bond, and I could delivered it by the sandwich technique in just 2 steps. The first step and the remaining part by the visco expression, as you see here. Then IA through this paracentesis or the side port. I mean, to keep the system closed, and finally the implantation of the BMMA in bag by the axial rotation, and finally the stromal hydration of the old ones, and leaving the globe with no sutures at all, just cauterization of the both ends of the conjunctiva with no problem at all, and coapted formed antechamber. Phaco in Caracta Negra, the same situation with Phaco, and I actually was the same surgeon in both surgeries. I tried many times to keep the cornea cooled with the less power and the viscoelastic injection every other minute, during the phacoemulsification, keeping in mind the endothelium and keeping in mind as well the bag and the posterior capsule. Because in phaco you will do a lot of the manipulation in the antechamber and in the vagal level. So in the old age, you are at risk of both endothelial injury and actually the subluxation and xenodialysis. Look here, the difference between this is the both eyes 2 days post-operatively. On your left side, the phaco with blepharospasm, with a minimal edema, and the patient cannot tolerate the the usual or the normal lights, while the other eye is open confidently, and the cornea is crystal clear with dancing air bubble and the good luster of the cornea. So the message from this video could be is clear and could change our minds regarding the manual small incision cataract surgery, especially for the phaco surgeons who are rejecting or refusing the technique all the time and calling it the poor man phaco or the old traditional technique. But it could be a very good solution and a magic solution in such case. Look here in this terrific case. It's very dense brown cataract for a woman of 82 years old. And look here, very dim red reflex. I tried to get it by the red reflex mode of the microscope and tried, excuse me. Yeah, this is technical error, and try to complete my rixes through this dim red reflex with no stain, with no need for the staining. And the patient told me many times, please, doctor, I'd like to do this surgery by the phaco for me. She heard a lot about the phaco, the ultrasonic, by the femtosecond and the femtocataract. I told her I would be responsible about the decision intraoperatively on table because I see that your cataract is so hard, and so the machine won't be able to bite this cataract. This cataract, very dense brown, going to be cataracta nigra as well, with calcification and deposition of a lot of crystals. So I tried many times by 100 torsional power and around 10 ultrasonic longitudinal power. I was afraid of hitting the corneal endothelium and realized that this type of cataract needs this driller, not only the phaco machine, and shifted my mind and took immediately the decision to convert from this technique to the manual small incision cataract surgery, keeping the cornea clear and keeping the bag intact and keeping the patients happy and seeing well after the surgery.
It's almost time, sir.
Yes, time is almost up, Dr. Hosam.
The time is out?
Yeah.
Okay. So I have to conclude. I will be faster. I delivered this nucleus and then removed the nucleus from the tunnel and visco expression and implanting the IOL with very easy steps. And finally, to finish, I have to show you the patient 2 days post-operatively with this very crystal clear cornea
Wonderful cornea.
and seal wound and vision of 612 unaided and best corrected with this minimal refraction to be 6.6. And thank you so much.
Yeah. Thank you, Dr. Hosam. I want to ask Dr. Helena Pryor Felipe. Dr. Helena, yeah, you're there. See, in your country, what is the trend? Everyone is doing exclusive phacoemulsification, or in cases of hard cataract or difficult situation, they convert to MSICS. Can you just throw light upon the situation in your country?
Well, thank you so much in the first place for being invited and being part of this exceptional family that is the one from ISMSICS. It's an honor to be here. And thank you to technology as well for making this possible for ourselves to be around the world and nevertheless manage to be together. So in my country, as in the majority of the, I would say, Europe, MSICS is not the most common surgery that is performed. The most common surgery, the most common technique that is performed is phaco. Nevertheless, we still have cases that present challenges in the case that in the whole presentation of Professor Hossam Ziada is exactly pointing the right situations that we also still find as well in our country, in this part of the world. There are sometimes very rocky cataracts, hard cataracts, sometimes also coupled or not, but with a low endothelial counting. And those cases are more clinically advised to be managed by ESCC or MSICS than to perform phaco. And we all know we have this experience of, being very excited about phaco and how we can extend the indications of performing phaco in terms of cataract surgery because of many aspects that we could also think about and discuss. But the idea is to highlight the importance in the place and the role that this technique still has, and also to make a point of the importance of developing skills in teaching and learning about how to perform it. And this is more and more something that should be, and I would say that is increasingly approached, the importance of this learning and teaching the technique, because we can run the risk that new generations can be so much detached from the whole mindset and how we, and the practice of ECCE or MSICS.
Yeah.
For working with technology, not so much with the art and science and dexterity and other aspects that these kind of techniques require. And also to widen, there's a very widening and increasing interest of residents, for instance, to have the sense of how ophthalmology is being led around the world and the differences that the ophthalmology also proposes around the world. And it's such a rich and varied specialty that can span from, just very primary care to other more technology aspect related issues, and also the differences in diversity that we can find around the world. So this is exactly the point that we should teach and learn about how to perform ECCE and MSICS. And for instance, we I will finish in a minute. We will have a presentation on exactly something that is so important, that is including modules in simulation training, including modules of MSICS. And for that, Van will probably be speaking and emphasizing that, Professor Lansing. Thank you.
Thank you, Dr. Helena. I'll request the next speaker, Dr. Gonzalo.
Thank you so much for the presentation. That change and magic. I'm sorry to interrupt. I would like just to emphasize the words change and magic resonated very much. Thank you. I will shut now.
Thank you. I would request Dr. Gonzalo to start his talk on hybrid MSICS. Dr. Gonzalo, please.
Okay, is the presentation okay? Are you seeing the presentation? Okay,
yeah, we are seeing.
Perfect. So, hi everyone. First of all, it's a pleasure to be here for us as LATAM chapter with Dr. Gines, and thanks for this kind invitation. So I'm gonna talk today about the hybrid MSICS, and wait. Are you seeing this one, this presentation?
Yes. Yes, we are seeing.
Sí, Gonzalo.
Okay, perfect. So in Latin America,
Sí, usa.
nearly all modern cataract surgeons in almost all countries are formed with phaco. Nobody knows so well the MSICS technique. So here is this presentation is about the hybrid MSICS. So the hybrid MSICS is a cataract surgery technique that combines some steps of phaco and some steps of MSICS. And I think, personally, I think is the best way, the safest bridge between the phacoemulsification surgeons to learn MSICS. So the MSICS contains several critical steps, and I'm gonna talk about these critical steps. The first one is the sclerocorneal tunneling. You can do like a straight, frown, chevron, and he has to be 2 millimeters from the limbus and 6 to 7 millimeters width. You do the scleral dissection with the crescent blade, and also the crescent blade you have to tilt and rotate to match the contour of the eye. In this step, you can have some complication like this one, the buttonhole, and the other one, the other complication here is very common in the first cases are the prematurate entry to the anterior chamber. Also, the other critical step in MSICS is the nucleus prolapse.
There's sclerosis.
If you have, for example, a soft cataract, you can do the hydroprolapse. That it's so similar of the technique the phaco surgeons do when they want to do the phaco in the anterior chamber. So you luxate the nucleus with hydro dissection, and the other technique you have to prolapse the nucleus is the Sinski prolapse. In this case, you use one Sinski hook to take the nucleus into the anterior chamber. The problem here is that you can stress the sonula in the pseudoexfoliation cases, for example. So I recommend this technique for hard cataract, the bimanual prolapse. That means you use two instruments, two Sinski hooks. With the first instrument, you can rotate the nucleus to one side, and the other instrument you put above the nucleus just to luxate the nucleus into the anterior chamber. So that's, I think, is the safest way to luxate the nucleus into the anterior chamber. And the other critical step of MSICS is the nucleus delivery, that when you have a soft cataract, you just can do the viscoexpression, is the safest one, and it's so easy. But when you have, for example, a hard cataract, you can do this nucleus delivery technique. That means you use a irrigating vectis above the nucleus, and I mean under the nucleus, and you can take out the nucleus of the eye. And this technique, I think, is the best one to hard cataracts. Is called phaco sandwich technique. That means you put the vectis behind the nucleus and the Sinski hook above the nucleus, and you made a real sandwich with the cataract. And this one is so good technique because you can prevent the damage in the endothelium. So it's a really good technique. It's a very safe technique to take out the nucleus of the eye, especially in hard cataract. You can see this technique for other view. That one is the phaco sandwich technique. And to finalize the presentation, you can see here a 2 minutes video with the technique I prefer to do MSICS. That it's a mix between steps of phaco and steps of MSICS. So I'm always want to have a good place to work. So if I don't see a lot of sclera, I use a suture to have more sclera to do the tunnel. Here I made the sclerocorneal tunnel with a crescent blade. I always do at least 7 millimeters and 2 millimeters from the limbus. Here I made the capsulorhexis by the cornea, not by the sclera, because for me is I think I am more used to do the capsulorhexis by the cornea. And also here I luxated the nucleus into the under chamber. After that, I made the incision with this blade, and I made the phaco sandwich technique to take out the cataract from the eye. And when you do this kind of surgery, you don't have to use the most of the cases sutures for the sclera. You do the sutureless MSICS. And after that, I remove the cortex, like usually I do with phaco, and suture or cauterize the conjunctiva. So this is the technique I recommend for the phaco surgeons who wants to switch into the MSICS or want to start the first cases with MSICS, because they can mix the steps of phaco with the steps of MSICS. I think it's the safest way to start MSICS surgery. Thank you.
Very nice presentation, brother.
Thank you. I think I...
So, Brahmani, are you here?
Yeah, I'm here.
Oh, sorry, I was muted. Dr. Parikshit, can you comment on your take on this hybrid technique? Dr. Parikshit Gopte. Yeah, just wind up in 2 minutes. Your take on this hybrid technique.
So the take on this is what the doctor has said is a hybrid thing, because in most of the countries in Latin America, they are completely into phaco. Even in Europe, they are completely into phaco, also in Australia. So there we know, like what Dr. Hassam Zaida showed, there are problems when you do cataract and nigra, when you do very hard cataracts, when you do hypermature cataracts. So something like a hybrid technique is really needed. One, because it's easier for the surgeons to get into that technique rather than learn manual small incision right from scratch. That is one. And second, in many countries like in Germany or Spain, for cataract surgery, if you want it to be reimbursed or for insurance, phaco is considered the only way of doing cataract surgery. So if a doctor says that he's going to do something different, he may land up into a lot of other hassles, legal hassles, or hassles with authorities or insurance companies. So what Dr. Yara has shown is, I think, something that we should all work on and we should all popularize so that it becomes easier and patients will benefit and more surgeons across the world will pick up manual small incision surgery.
Okay. Thank you. Thank you, Dr. Parikshit. The next speaker is there, Dr. Jon Carlos Genis. I think he's giving a talk in some other webinar. Oh, sorry. I'm sorry. I missed you.
No, he's very much here, sir.
Yeah, he's very much here. Sorry, I didn't see you. Kindly start your... Yeah, you must have...
I finished a talk for Peru. Yeah.
Thank
so
you.
Let me just...
Yeah. He's going to speak on 5 important pearls, his pearls for MSICS.
Let me just open the presentation here, and this is it. This is it. So it seems we need another pandemic to get to know the Zoom again better. There you go. So this is it. Allow me to move this.
Don't worry, don't worry, Carlos. I think it's coming.
There you go. Okay, allow me just here. Okay, I pre-taped this so we don't lose precious time. Here we go.
Yeah, pinch the full screen.
Yes, we can see your screen, doctor.
Doctor, can you make it in a slideshow mode, please? Can you press the play button on top? Yeah, it's
I'm
stopped.
sorry. Okay, it didn't start it. I was seeing it. No, sorry.
It's gone from the screen now.
Uh,
We can't see it.
Juanca, se vio
Okay.
una presentación de queratopatía neurotrófica, por si acaso.
Okay. Sorry, I'm gonna close this one. What's the other one here? This is the one. Please tell me if you can see this.
No, sir.
No?
No, sir, can you reshare? You need to reshare, doctor. It stopped.
I'm sorry. The sharing stopped. So this is it. There you go.
Ahí está perfecto.
Okay.
Perfect, sir. Perfect, doctor. Dr. Juan, we can start.
Sorry, you can't hear it?
No, we can hear you. You just need to start. The setting is okay. You can just click on. You stopped
I'm
again,
sorry.
Dr. Carlos.
Yes, I know. I'm sorry. It didn't work, but I taped this. I was hearing it twice already.
No, it was working.
So,
You can start.
Ya, ahí está
okay,
bien,
good.
ahí está bien.
Perfecto. Bueno, vamos. So, can you see this?
Yes.
Se ve la primera diapositiva, sí.
Okay, good.
Yes.
So, sorry.
Yes,
Bueno,
it's okay now.
good. Namaste, my friends. I would like to sincerely thank the organizers for the invitation to participate in such a distinguished session at a prestigious congress like this. I only have 5 minutes, so I will go straight to the point. Today, I would like to share my 5 pearls for manual small incision cataract surgery. I consider myself a skilled surgeon, but I believe my greatest strength is mastering this technique, which allows me to manage almost any type of cataract under nearly any circumstance with consistently excellent outcomes for my patients. My first pearl begins with wound construction. During manual small incision cataract surgery, we must manipulate the conjunctiva and Thenon's capsule as little as possible, ideally touching them only once throughout the entire procedure. Whenever possible, we should dissect rather than cut the tissue. The less trauma we create, the less postoperative inflammation we will see, resulting in faster recovery and a much better cosmetic appearance during the healing. My second pearl is the importance of creating a clean scleral tunnel. The incision should be made in one smooth and controlled movement parallel to the limbus, regardless of the instrument being used, whether a blade or a crescent knife. The goal is to perform a single clean dissection until reaching the depth where the tissue color changes, indicating that we are approaching the gray zone. That should be our limit. The next pearl is understanding that the tunnel is a three-dimensional structure. Because we are operating on a curved globe, the tunnel naturally curves towards the sides. Therefore, when dissecting laterally, it is important to slightly tilt the crescent knife to maintain the correct tunnel architecture. Another important point is nucleus luxation. This maneuver can be performed using 1 or 2 instruments. And using 2 instruments often makes the procedure easier and safer, like my colleague just referred. We frequently use what we call the slingshot technique, where one instrument provides counter traction while the other helps luxate the nucleus. This is especially useful in small pupils because it also assists with pupil manipulation during nucleus delivery. However, this maneuver must always be performed very carefully. My fourth pearl concerns the use of the vectis. During nucleus extraction, the vectis should be tilted slightly downward and towards the surgeon, away from the corneal endothelium. Maintaining control during this step is critical because endothelial damage may occur if the nucleus suddenly rotates or flips during delivery. Personally, I recommend placing at least one suture in the tunnel to minimize any possibility of communication between the external environment and the interior of the eye. This might be an interesting point to discuss. I have seen endophthalmitis due to sutureless surgery, so I was cured forever. Not my patient, but I would never do a sutureless one. Finally, I would like to share what I consider the most important lesson. During my residency, one of my mentors taught me that cataract surgery is a procedure made up of perfectly executed steps. Every single step must be done correctly, because otherwise we spend valuable time trying to fix avoidable problems and complications created by imperfect execution. So, thank you very much once again for the invitation.
Thank you, Dr. John. I request Dr. Purvi Bhagat to give her comments on this technique, the 5 pearls told by him, and especially your comment on whether it should be always sutured surgery. Dr. Puri, please.
Yeah. Thank you, Dr. Yuan. They were wonderful pearls, actually. And I very much agree with what he has said, that the handling of instruments and how you move at your wrist joint and the leverage that you give to the instruments is very, very important. Like, because if you hold the instrument in an improper way, you are likely to have complications like either the premature entry or there is a tearing of the roof, and all those complications are likely to happen. So for beginners, how to hold an instrument and how to move them correctly is very, very important, as he very nicely highlighted. Second thing is about the tunnel. What he very nicely demonstrated and said is, because these are pearls which are often overlooked, but they matter a lot in surgery, like a single sweep for the tunnel making. Because sometimes at beginners, they just keep on scraping and create multiple planes in the tunnel, and then for the nucleus delivery, IOL insertion, and everywhere there is a problem. So again, thank you for highlighting that very point, that the tunnel has to be a very clean single sweeping movement from one side to the other. And nucleus delivery, of course, he nicely demonstrated that technique. But again, there are lots of techniques as shown in the earlier presentation. So one can do whatever suits best and is best comfortable with. And again, taking care of the contour of the globe, see whether hooking is nicely done or phaco sandwich or whatever. So those points are very nicely elaborated, and I'm sure that they would be very useful for all beginners who are venturing into MSICS. And considering your question, sir, on suturing, yes, everybody is in the fancy of doing a sutureless cataract surgery, but one should not hesitate to take a suture whenever you feel the need to be. Like if the tunnel is irregular, it is very large, you feel it's leaking, it's better to take a suture and be comfortable and sleep in peace, rather than having to take the patient in the OT again either next day or next week for an iris prolapse happening through the wound.
Yeah, thank you. Thank you for this comment. So it's a airtight, watertight wound even in MSICS. It is a safe incision because of the covered conjunctiva. But if you feel that the wound is not watertight, airtight, you should not take the risk and suture the wound, so that there is no risk of endophthalmitis also for the iris prolapse. Thank you very much.
Thank you.
I request Dr. Van now to speak on what are the benefits of MSICS in the Western world.
Okay. Can you see the screen there?
Yes, sir.
Yes, sir, coming up.
Great, thank you very much. And I'd like to comment that Punil mentioned to sleep in peace, which is not rest in peace, no? So, because that can also happen. And Juan Carlos, it's always good to see one of my former students being such a brilliant surgeon and instructor nowadays. Okay, so I'll depart a little bit of what everyone else is doing, just to really take a moment to see what is the goal when we're training people. Is it to do a lot of surgery, to do it quick, to do many surgeries and do them quick, or to do perfect surgery? Regardless, seems to be a competition that we need to do it in 5 minutes, in 3 minutes, in 10 minutes. But I think really we have to think of competency. So Juan Carlos has achieved that in 80 surgeries. Some others might do it with 100. And then there's some others, which I won't mention the name of, a former colleague of mine, that 300 and still he wasn't a surgeon. So it just depends. We have to think of qualified. Why is this important? Because if you see this is a previous paper that we published together with Dr. Serge Reznikov. The prevalence of blindness doesn't have a real strong correlation with the number of surgeons doing out there. Because as you probably know, many of the RAP studies have shown that the second leading cause of blindness after cataract is cataract surgery. Some of the results of cataract surgery out there are very poor because people are not trained to do them. Also, the number of ophthalmology, well, this is repeated. So what are the selection criteria? Each one of you will have different ones. Do they have stereopsis? Is there hand dexterity? What is it that we're looking for them? So the question is, should there be global standards in ophthalmology training? I believe so, but we know that there's different ones. Here you can see from the UK that also there is a difficulty in selecting residents and fellows to have a gender balance. Then how are we tracking the performance of that surgeon or that resident in training? So essentially what you can see is that over time, the trainees develop that competency. But what you can see is that in 100 videos, they only achieve that competency after 760 cases. Is that really what's happening, or how are they being trained that they can only do that later on? So the European Board of Ophthalmology is moving in that direction. And like many other papers, they see that after 80 surgeries, you achieve that level of competency that we're working on or aspiring to have, and 300 for proficiency. The ACGME in the US also speaks about 86 cataract surgeries to achieve that level of competency. The Brazilian Council of Ophthalmology, roughly the same number, where it says the below one atendimiento quirúrgico. So they're aspiring for 150 cases in the 3 years of training. So roughly also in that level. India, similar thing, around 80 cases, give or take. And the AUPO, the Association of University Professors of Ophthalmology in the US, is also now moving in that direction, staying away from numbers. What we want is competency. And Dr. Helena Felipe, who is here with us, she is one of the best people to speak about moving in that direction of competency. I'm sure that it would be great to hear her opinion on this, and I don't have the time to discuss all these things, but I think that's a message that we want to convey. So what are the key aspects of competency-based education? Is focus on the learning outcomes and personalized training. Not every single trainee learns in the same way. Also have the proper feedback. That's part of what we should all be aspiring to do it. Now, this is an interesting thing, and this will be one of my last ones. Dr. Anne-Sophia Thompson, one of the best experts in simulation-based training, what she was able to demonstrate with phaco a few years back is that that same level of competency is achieved if you've been trained with simulation with around 40 cases. That means that you can put more cases throughout the day, surgical day. You'll have less complications, less lawsuits, etc. So simulation is the next bridging point to be able to reduce those problems that we have. And this was achieved. This is a paper that was presented a couple of years ago by the Aravind team using after simulation at the ASCRS meeting. And essentially what you can see is that by using simulation, the average number of complications that first-year residents had, that was 3.6. After simulation, it comes down to 1.2. So it's a 60% decrease. So simulation definitely has a place. And so I think we have to be comprehensive how we're teaching. Yes, wet labs has a place. Simulation, supervised training, case video discussions. So remember that one of these trainees will be the ones that will be doing our cataract surgery, all of us here. So I expect Juan Carlos to do my cataract surgery after I develop it to feel responsible. No? So and this slide, and it's not showing, I don't know why, this was provided to me by Dr. Helena Felipe in the PAO meeting, which I think it summarizes everything what we're trying to do, which at the end of the day is to improve the outcomes for all the patients. And with that, I'll stop and open for comments. Thank you very much.
Thank you. Thank you, Dr. Wan, for beautiful presentation. You are associated with training on surgical simulator. Dr. Pamela also is associated with training on surgical simulator. So I want her comments on your talk.
Hello, Dr. Boramani and everybody. Thank you so much for the invitation and for having the Mexican Center of Cataract Surgeons as a co-host of this session. So this is a wonderful presentation, Dr. Van, and it's actually true. I mean, even though there are numbers that different organizations have said about setting the minimum standards for having a proficient surgeon, cataract surgeon, I think in Latin America we are lacking of that standardization because especially leaving cataract surgery aside just for a little while, even for the ophthalmic residency training program, there's a huge difference. You can find programs that would last like 3 years, but you can also find programs that would last like 6 or 7 years here in Latin America. So I think, as you said, standardization, it's a very, very important thing. And I also am a truly believer, and I have seen during these past years that simulation definitely helps us to bring that gap shorter. It definitely helps the trainees or even the experienced surgeon to manage a new technique. As all the professors have been saying, it is a very, very useful technique. I know there are a lot of different ways of doing MSICS all around the world, but I think the most important thing is to have it, as Dr. Amulya Sahu taught me a few years ago, as a tool for the cataract surgeon, for becoming a complete cataract surgeon. We don't have to say it is better than phaco. No, it is just a very important tool that will definitely help us to have a better attention and better results for our patients.
Thank you. Thank you, Dr. Pamela. We request Dr. Karamjit Singh now to talk on 2mm MSICS. This technique has been taught to him by Dr. Amulya Sahu, and now he is teaching his students in Amritsar the 2mm SICS technique. So let us know the benefits of 2mm SICS.
Thank you, sir. Good evening.
Good evening,
everyone. My screen. Is my screen visible, sir?
Yes, sir.
Yes.
Yes, it is. It is visible.
Yes. Thank you, sir. Thank you very much. Actually, I am traveling from Uttarakhand. So I beg your pardon if there is any difficulty in connection. So my experience with the 2mm SICS that I learned from Dr. Sahu, and I am practicing this technique for last 3.5 years. So 2mm SICS, particularly in our setup, it is sutureless, very easy to perform with lower astigmatism, and it is very cost effective. Although phacoemulsification is popular, but I find that 2mm SICS or even manual SICS, it is as good as phacoemulsification. So basically 2mm SICS is the most important point in that is incision construction. So my incision is basically, it is 1.5 mm away from the limbus, and it is 2 mm horizontal cut, and after that 2 mm vertical cuts toward the fornixes. And the inner incision should be slightly, or you can say that depends upon the size of the nucleus. So in very large nucleus, it should be around 6 mm, and in small nucleus, even 4.5 or 5 mm is sufficient. So this is my surgical technique. This is my old video actually. So first we mark the incision 2 mm and two back cut of approximately 2 mm. That depends upon the size of the nucleus. Then the sclerocorneal tunnel, as usual, as we do in manual small incision cataract surgery. And the side extensions of the incision. The inner incision should be larger than the outer incision. Then after that, good large capsular access as usual that we are doing, and extension of the inner incision. So you can see that practically the outer incision is approximately 2 mm. Then expression of the nucleus into the anterior chamber, which is after a good hydrodissection. So this is, I divide the nucleus into 2 or 3 pieces with simple visco dissection. I use visco cannula only, and after that with specially designed vectors, 2 mm vectors by Dr. Sahu, I express out the nucleus. So this is, and after the washing of the retained lens matter, I put foldable or non-foldable IUL of, if non-foldable, that should not be more than 5.25. So practically you can see that the outer incision is approximately 2 mm. This is another case. So incision construction is the same. So I am fast forwarding this for the sake of time. Then good capsular access. So we need a little bit large capsular access in this, and good hydrodissection, which is very important, and extension of the incision. This is very important. So when nucleus is a little bit larger, then you need little bit larger inner incision. So in this, basically I divide the nucleus into 2 pieces in the bag only with this manipulator and the chopper, the pre-chopper, and with this vectors, I express out the nucleus. So this technique is very simple, and it is as good as phacoemulsification. So these are the instruments that simple instruments that we use in this 2 mm incision. So we did a study on 300 cases approximately, and we find that there is endothelial cell loss in SICS, which is quite less as compared to phacoemulsification, and which is comparable at day 42. So these are our results. So we find that the anterior surface astigmatism, it is more in phacoemulsification group as compared to the manual small incision cataract surgery. So this is the mean surgical induced astigmatism, which we find that it is more in phacoemulsification group as compared to the small incision cataract surgery. These are the few post-op pictures of my cases. So to conclude my talk, the visual outcome at 6 weeks were comparable in both the groups. Although in group 1, it showed a greater endothelial cell loss because of use of phacoenergy as compared to the manual small incision cataract surgery, and also anterior surface astigmatism and surgical induced astigmatism, it is higher in phaco group as compared to the SICS group. So despite these two different techniques, the visual outcome, it remains the same in both the groups. So initially we find that there is a little bit corneal edema at the incision site, but it goes by fifth or seventh day in 2 MSICS technique. So these are my reference. So thank you very much for patience healing.
Thank you. Thank you, Dr. Karamjit. That was very important conclusion as far as the endothelial loss as well as the induced astigmatism is concerned. Maybe you can do one more study of regular 2 MSICS and a regular 6 MSICS. The endothelial loss as well as the...
Sir, in my institute, I am comparing now the three incisions, 2 mm, 3.5 mm, and 5.5 mm incisions.
Okay.
So that I think after that, I will present my results after the completion of that study, sir.
Sure. Quick comments by Dr. Neeta Dodwar on this topic, 2 MSICS.
Thank you, Dr. Baramani. Am I audible?
Yes.
That was an excellent demonstration, Dr. Karamjit Singh. That is a 2 mm. And definitely you showed the studies. The cases are showing there is a less astigmatism as compared to phaco, and also the endothelial cell was less. So my advice for the beginners that you start this when you're doing a 6 mm incision, slowly start reducing your incision to 4 to 4.5 mm. See how is the result. The main difference of your phaco technique and SICS is your first is incision and second is your nucleus management. So once you reduce your incision, the nucleus management becomes tricky. So you choose the nucleus which are little soft nucleus grade 1 to 3. And initial when you are able to manage any grade of the nucleus through relatively lesser incision, you can start doing this. You need a lot of training. Once you are done hundreds of cases of normal SICS, giving good results without any astigmatism or without any corneal endothelial loss with the clear cornea, yes, you can move because it has a promising result and it is a great innovation. All the best to you, Dr. Karamji.
Thank you,
Dr. Neeta. Now our next speaker is our Health Minister, Dr. Kadil Jojo from Philippines. He will be speaking of 3.5 mm micro MSICS, the phaco non-phaco Philippine experience. Dr. Kadil, please.
Thank you very much, sir. I'm sharing the slides now. Okay. Is the sound good?
Yes. Make it full screen.
Yes. Okay. Thank you very much. Good evening to Dr. Saho, Dr. Baramani, the distinguished speakers, the panelists, and all the participants in this prestigious webinar. My topic for this evening is the 3.5 mm M6, the phaco non-phaco technique, the Philippine experience. There is a basic question that we have here. Can we do phaco result without the machine? So the answer is definitely yes. With this, I would like to do a little of history, starting from, in my journey from 1995 using the standard Arabian technique, and then later shifted to hook sandwich technique when I had some problems with the delivery of the nucleus, and also the post-operative astigmatism and the complications of iris prolapse. Since 2023, I shifted to a smaller wound. Before it was the standard 6 mm, then I reduced it to 5 mm, and now I'm using the 4 mm for the past 2 years. But this kind of technique, as inspired by the 2 mm technique of Dr. Sahu, I tried it my way, but failed miserably. So I stick to 4 mm, and later shifted to a little more reduced incision side, which is 3.5 millimeters. In this technique, you can do it either you are in superior, superolateral, or in the temporal side with a 3.5 millimeter sclera incision. That the secret here is the side pocket, wherein you put an adequate space for you to maneuver the nucleus, particularly if you are dealing with a very hard cataract, the grade 4, or even the brunescent or the cataract nigra. And the wound, the tunnel length is approximately 5 millimeter, while the internal wound is between 11 to 12 millimeters, so that you can deliver the nucleus safely without injuring the endothelium. So if you look at in the planned incision, the shape of the tunnel is like a laughing shape, while in the internal incision is a smiling wound. The delivery of the nucleus is facilitated by the instrument that I developed years ago, and of course the second instrument. So you can see here, initially the 4 millimeters, and on the left side, on the right side is the 3.5 millimeters incision, the technique. And as in advice to the beginners, always use the very sharp instrument. Do not use the dull one because, as mentioned earlier, you might be creating multiple planes, and we don't want to do that because we would like to avoid the leakage of the wound. And using the cartwheel maneuver with two instruments, and the delivery of the nucleus with the hook and the lens loop beneath, making sure that we don't touch the endothelium and do not injure any part of this very sensitive tissue. And once we insert the lens, either using the injector or just the capsule holder, the foldable lens holder, then you can safely introduce the lens into the position. We can use either monofocal or multifocal or even the premium lenses. So here, the comparison between the patient A and patient B. One is 4 mm and the other one is 3 mm. You see in the result, the wound is visible after 2 weeks, and then the lens is already very clear with a very clear cornea. On the second case here is the 3.5 micro M6. It is still similar in the approach, the technique, the use of the side pocket, the adequate internal wound, but the only difference here is when we put the lens in place. Initially, the first two cases, we use the injector into the main wound. However, on this case, I decided to put it using the side port as if I am following the typical phaco technique. So here the standard technique is being followed. The internal wound is being enlarged and then followed by the delivery of the nucleus using the hook and the lens loop. So very easy to remove. And sometimes if the wound is a little bit tight, or the nucleus is very big, you can experience some difficulty, but you can easily fracture the nucleus in the wound itself without touching the endothelium. And after thorough cleaning of the cortical materials, you can now insert the lens using the side port as the side for inserting the foldable lens. So with a little manipulation, you can put the lens in place and you can be confident that this is a very good technique. So you can see the post-operative result on the right-hand side with minimal bleeding, as well as cosmetically, it's very acceptable, just like the phaco technique. Although we cannot avoid some area wherein visibly there is a former signs of bleeding, but in 1 week's time, it will clear eventually. So, in conclusion, when we say phaco, non-phaco, micro M6 technique, it is very much achievable with meticulous and careful execution of surgery using different foldable lenses available, either multifocal, the EDOF, the toric, accommodative, and now the EMB or autofocus. And of course, with constant practice as well as feel, you will develop the confidence and you can predict the complications. And of course, we expect excellent results, either cosmetically or even the visual rehabilitation that all surgeons wish to have. And if we ask ourselves, is phacoemulsification always superior than M6? Then maybe it's not true at all because there are some M6 surgeries which is a lot better than a complicated phacoemulsification. So it depends on us. And with that, thank you very much for the opportunity to share. And namaste. Thank you very much for all our mentors and our participants, including our speakers in this evening's affair. Good evening. Assalamu alaikum.
Yeah, thank you, Dr. Kadil Jojo.
Assalamu
Now, let our final speaker finish his case presentation, then we'll take up some discussion again. So I request Dr. Miguel Lieto to show his interesting case presentation, blue pill versus red pill.
All right, thank you very much for the kind invitation. Let me just share the screen. Let's see if you can. Okay, can you all see
Yes.
my screen? Okay, perfectly. So thank you very much once again for the kind invitation. My presentation is going to be a surgical video from a patient that we did surgery on just last week. And this is the title of our talk because all of us are accustomed to one type of cataract surgery method. In my case, is a phaco, but sometimes we need to switch our decision in the middle of surgery due to complex anterior segment surgery. So that's what we're going to see today in this case. So this is a 90-year-old patient with light perception, bullous keratopathy, very small anterior chamber, pseudoexfoliation, phacodonesis, and a very hard cataract. As you can see, everything is bad in this patient. So how did I approach this? I thought about phacoing the cataract. So I put the iris hooks, then did the clear corneal incision, put the tryptophan blue, took out the corneal epithelium. But once I did the flap, I just saw how mobile the whole lens is. Not only the visibility is very bad, but the whole bag moves with the flap. And also downward, there's a slight subluxation of the lens. So now I'm getting worried. I'm trying my best to enlarge the capsular axis because I want to pop the nucleus out, do a flip and chip with the phaco, but it keeps getting smaller. And even though I'm trying my best to pull the flap towards the equator. So after much struggle, this is the decision that I did. I thought it was too small for it. So I did a can opener. And look how the bag, all of the bag moves with the cystotome. Even though I can open it, the interior capsule, the whole bag in every direction actually moves with the cystotome. So now I'm getting really worried. And so now I'm hoping that I can enlarge enough so I can pop it out with hydrodissection, which I'm going to try next. So I tried multiple attempts of hydrodissection, but the lens doesn't pop out. Actually, what happens is the whole complex keeps getting downward. So now I'm getting even worried. So I'm converting to MSICS, trying my best to do a very big scleral corneal incision. I use a mini crescent blade because I like to have control, and just like you said, do not come out of the tunnel. Do a enlargement motion, one enlargement motion for each side, so you can do only one tract where the cataract is going to come out. Then move forward into the clear cornea and enlarge it a little bit further. So after much attempt afterwards of trying to pop the nucleus out and not being able with either dissection, I'm going to convert to a different method after opening the wound. Here I'm enlarging it the best that I can. And now what I'm going to do is to use, just like the former colleague explained us, the two-chop technique. But the whole bag moves with the lens. So there's no way I'm going to pop this out. So I'm just converting it to intercap. I'm putting both choppers, trapping the nucleus, and there you go. I put it into the anterior chamber. This is the best way that I can do it. Then I put the vectors on, then try to bring it all in one motion downward through the scleral incision. Now I'm pulling the eye a little bit downward. There you go. I did not irrigate because I don't want the vitreous to come out any even further. So then I did the anterior vitrectomy with triamcinolone. There you go, not through the tunnel because I don't want the vitreous to come out there. I'm doing through the two incisions, corneal incisions. Then I put the artisan lens. I verify the vault. I like to put the artisan lens always behind the iris because I'm a corneal surgeon, so I don't want anything to to be even close to the cornea, endothelium. So now this is how I do the artisan lens implantation. I just put one of the ATICs behind the iris. Then I leave the lens. There you go. I'm going to pop it. There it is. One ATIC is stuck. Then I grab it again with the other hand and then put the other one. And I am trying my best to put it right there. There you go. So the pupil looks pretty good. So I'm going to do a iridotomy. But of course, as with all my surgeries, I always get a female from iridotomy. So probably going to have to change my technique with that. So I'm going to put right away viscoelastic, cohesive, so I can stop the bleeding. And as the clot is forming, I'm doing the DSEC surgery. So I'm scraping the desme layer, then I'm pulling towards the center. Because I use the blue stain dye, I can see clearly, even though I have a very severe bullous keratopathy, I can see clearly the membrane. Now I'm taking out the viscoelastic with IA. I like how the eye stays formed. Then I put 3 stitches on because I want to put an air bubble in the end. Then I close the conjunctiva. Then I put my DSEC graft inside the eye with a boson glider. And then I put the air bubble. And look how the air bubble stays inside the eye, even though I have a very big incision, scleral colon incision. So now I like to burp it out the liquid between the graft and the donor's cornea and the recipient cornea. And that's it. That's the case. This is the first day post-op, still a bit of edema, but you can see the graft is well centered and it has only 70 microns of thickness. Thank you very much for your attention.
Thank you. Perfect.
Thank you, sir. It was a fantastic presentation. The carry-home message is surgeon should leave aside his ego and do whatever is best for patient's vision as well as for the patient. So Dr. Annu Malik is a professor from India's premier institutes. I would request her to give her comment on the last 2 topics or maybe any of the topic of her choice. But you try to finish in 2 minutes so that our counter chairman can have his concluding remarks. Dr. Annu Malik, please.
Thank you so much, sir, for giving this opportunity. Sir, I have a question also for Dr. Karamjeet. Can I ask, sir?
Yeah. You have any comment for any talk? You are wondering why?
Yes, sir.
How can we do 2 mm for a hard cataract?
Yeah, sir. I would like to know that. Would you attempt a 2 millimeter MSICS for a grade 5 luminescent cataract?
Dr.
No. I think it is very difficult to manipulate the nucleus or express the nucleus through 2 mm incision when the cataract is grade 5 or it is very hard. I think it is very difficult to break the nucleus into multiple pieces. So I usually don't do these 2 mm SICS in hard cataracts. So
And so what nucleus?
cataract 2-3 grade, they are most suitable for 2 mm incision. Even if it is grade 4 little bit, I can break that cataract into the bag and try to express out that nucleus out of 2 mm incision. But in those cases, I find that there is a little bit more endothelial cell loss, and there is a persistent corneal edema for a few days after surgery. Although after a few days that edema subsides with the medications or so, but I never attempt 2 mm incision these days in very hard cataracts.
Okay, thank you,
it
sir.
is not advisable to.
Thank you, sir.
Yeah, we are left only with 1 minute now. I think.
So, sir, considering that case for DSEC with MSICS, so the choice depends upon the surgeon, the nucleus density, the corneal opacity, and definitely the surgeon expertise, and not just the dogma. So, dense cataracts, mature white cataracts, and poor endothelial reserves, if we have, and moreover in resource limited settings, we can go for MSICS with the endothelial keratoplasty.
Correct. So I thank all the speakers and the discussants for a wonderful session today. I request our founder chairman of ISMSICS, Dr. Amulya Sahu sir, to give his final comments on the session. Dr. Saur, sir, please.
Yeah, it has been wonderful listening to all the wonderful speakers. See, what I find that Europe, they are brilliant surgeons, but they should learn SICS properly, and there is no question of economy involved here. It is an art form of cataract surgery, and to our bad luck that when the phaco started coming, all the big economies gave up their skill. So it is time for them to return to the skill-based surgery also and keep both the things. So you become a complete cataract surgeon. You should not say, I'm a phaco surgeon and SICS surgeon. A good surgeon or a bad surgeon. If you are a good surgeon, you should be a complete cataract surgeon. It is not good. The patient is not coming to you for your machine. It is coming to you for your skill and your expertise. So the whole idea that now it is time for us to become look beyond these limitations and start expressing ourselves surgeon-centric. People are not coming to like my friend Boramani. Somebody asks you, do phaco? He is doing SICS surgery. He's a phaco surgeon. He said that which phaco you want, cold phaco or hot phaco? And then the patient said that whatever you think right, you do. So that is the kind of patient is coming to you not for your machine. Now the machine marketing time is over. The surgeon marketing time has come. I am a best surgeon in the field. That assertiveness should be there. One of our friend, Dr. Raut, is doing totally MSICS and he charges 5 lakhs for cataract surgery and people pay him. So what I am thinking now, the surgeon's ascendancy should start. Europe has been totally because the machine people control the decision makers. So that is why even in China the students are crying here. Their superiors don't allow them to practice SICS because they have been in the pocket of machine marketing organizations. But I'm telling now we are taking the latest, even Alcon people who have given us the latest microscope to us. So I'm telling them, by your money and we are putting all kind of lens in SICS. So why don't you promote SICS also along with the phaco? So the money has no colors, whether it is coming from machine or coming through your lenses, that can be done. And besides that, what Karamjit has already shown, 2 mm, he is teaching to his student, he is given thesis paper on it. I think Fadil Jojo, who have been for last 20 years since he started in Malaysia, he has been consistently following doing SICS. He held in 2 mm. Please visit Karamjit and learn the 2 mm SICS and tell your organizers now that you are a minister. Philippines is not a big economy. Why should they spend so much of money on machines and other things? They can do a better thing. And India is being we have such a big economy, but we are doing all kind of surgery, phaco, SICS, everything. Same thing I want all over the world. People, big surgeons. I saw, you know, they're so good surgeons. They should now promote SICS and become best surgeons.
Okay, thank you, sir. I thank all the speakers, all the discussants.
And ISMSICS is always there.
Yeah, all the coordinators, and I also thank the Mexican Center of Cataract Surgeons for being our partners for this session. Thank you very much.
Thank you very much,
you, sir.
Dr. Borobani, Dr.
Thank you very much.
Goodbye, everyone.
Thank you.
Congratulations.
Bye. Thank you, sir. Thank you very much.
The coordinators.
Thank you, everyone. I'd like to hand over to the next session coordinators, Dr. Rodika, Dr. Ankit, and Dr. Gufran, for the masterclass on managing PC lecture.
Okay.
Thank you.
Thank you, sir. Thank you very much.
Thank you, Dr. Singh.
Hi, Rolika. Hi, Ankit. How are you?
Sir, fine, sir.
Hello. So our session, you're the coordinator for the next session?
Yeah, me with Dr. Olika and Dr. Gurfan.
Hello, sir. Good evening.
Hi. How are you?
Yeah.
So just to be clear that about the flow, I think Dr. Chang is joining. Welcome, Dr. Chang.
Hello, I'm getting my camera on. Hold on. Not seeming to get my camera, but I can hear.
Okay. Do you want to just check your presentation if it's playing all right?
Yeah. Let me just see what's wrong with my camera here. It's weird. Let me log off and log back in. See you shortly.
Sure. So just before he logs back in, to be clear about the flow, Dr. Ditial is not there, so there's no chairperson. So I'm just going to go ahead and introduce I'll welcome everyone. I'll introduce Dr. Chang. Rolika's forwarded his CV to me, and then we'll welcome back, Dr. Chang. How are you?
Thank you.
Yes. Can we check your slides?
Absolutely. Let me
Rishi, sir, everything okay here?
Yes, all okay. Thank you, Rolika.
Okay, sir. We have Dr. Gufran and Dr. Ankit also online with us.
Yes.
They'll help you coordinate the sessions. And thank you, Dr. David, for joining us today.
Yes, this share screen is a little different. It's asking, I don't see the advanced, I'm used to having, this is Zoom, and I'm used to having
Yes,
Zoom
this
where
is
I share not my window, but a special tab. So this is because
Dr.
I have,
David, the special tab will be at the bottom. And when you hover over the tab, it will show as an up arrow which says share.
well, yeah, no, I have that, but the share, usually with Zoom, there's an advanced, where I don't share the entire screen.
I'll have Mr. Sunil help you out. Sunilji, can you help us out over here?
Yeah, in most Zoom, you have an advanced, when it says share, it says advanced, and you.
Sure, just 1 minute. I'll just contact him and he'll help you out. Just a minute.
Can I have Dr. David? I'm not able to hear you. So, anybody is able to hear Dr. Chen? Hello?
How about now?
Yeah, perfect,
the
doctor.
problem,
Yeah, I can.
yeah, there's different Zooms programs, and this one let's try sharing of this one.
Do you have a share? Yeah. Just click on the PPT that is there on the desktop. You should be good to go.
Yeah.
Just click on the PPT that you have, the presentation.
Yes, I'm there. And the problem is that when I share this, you don't see.
Dr. David, can we do one step? Can you just stop share for a minute?
Yes, I'll stop sharing.
Just click on the share button once. Don't go sharing. Just click on the share button once. You will get a pop-up.
Yep.
On the right hand side, you will have show zoom control. Just uncheck that box beneath share sound on the pop-up itself.
There's also advanced tab on top.
And just go sharing. Just uncheck the Zoom meeting controls. Just show Zoom meeting, and you can go sharing. Or you can select the entire screen on the left hand side top, which says entire screen, and then share. And somehow your audio is gone again.
How about now?
Yeah, now the audio is there. If you can just try the sharing again, sir.
Well, I have three options: Chrome, tab, window, and entire screen.
Entire screen, sir.
Well, when I click on it, nothing's happening.
So just click on no, you will have to click the share button again. Once you click the entire screen, then on the bottom right, you will have blue button which says share. Just click on that.
Yeah, but it's not highlighting. It just says cancel.
You have to select the entire screen first. You will have to select the entire screen first.
Yeah, I did. Oh, okay, got it. All right. Now,
awesome. Now you can just click on the PPT that you have, the presentation that you have.
All right, there it is.
Perfect, sir.
But you're seeing the whole. You're not seeing just the screen. You're seeing. I have a long.
We are seeing the video. It's actually a skewed one, but I think we can make do with this as of now.
All right, but it's not filling the screen, is it?
It's displaying, sir. It's moving.
Yeah. All right, but
yes,
Sunil, is it full screen?
Sir, there is some issue, I believe. We have to do a technical R&D. I'm not trying to.
It's not full screen, Sunilji.
It's not full screen, right? Because there's this. I'm missing on this Zoom link. I'm missing a setting where I can customize my screen, and I have a special horizontal monitor. So the other option is I can drive to my office, which is 5 minutes away. And
so we can manage. I think we can continue with this with the paucity of time.
But the screen will appear really small to you and your viewers, is my opinion. Right? Can you hear me?
Do something, Sunilji, to make it a little bit larger.
So it will take an entire different set of settings as of now.
Okay. Okay. So we don't have any option.
Well, the other option is give me, we'll start 5-10 minutes a little bit later, but I will go to my office. And I'll use my computer there.
So the program moderators will be able to.
I'm sorry?
There's a problem, Dr. Chang. Our session is about to start in 2 minutes.
Yeah, but for a 1 hour presentation, let me just say something. For a 1 hour presentation, you're not going to see the videos, right? Because I'm sharing from a large.
What we can do is while we wait for you, we can have a discussion amongst ourselves for the audience, and we'll quickly wait for you to drive up and log in from your office. Is that okay?
I think that's the better thing to do. I'm sorry about this, but
No
I
worries
think
at
that's
all.
exactly
We'll wait for you.
the best
We'll
way.
wait for you, sir. That's not
Yeah.
a problem at all.
So I think I have the video. I have the link. I just have to set this up at my office. It has to do with the computer monitors, and I apologize. All right. So
no problem.
Sir, one request, kindly hurry up, please.
Yep.
Thank you. Thank you.
Yep.
Hi, Rishi.
Hello.
So we are live as of now. We are continuous live.
Let me welcome everybody. Hi, I'm Dr. Rishi Swaroop. I'm the moderator of this session. We have a very interesting session today. We have none other than world-renowned faculty, Dr. David Chang, who's going to be enriching us with a masterclass on managing posterior capsular rupture. All of us who are cataract surgeons know that that is the one thing that we're kind of not wanting during our cataract surgery. And Dr. Chang will tell us how to deal with these situations, how to avoid them. And I'm sure all of us are looking forward to learning from him. Unfortunately, there's been a small technical glitch because of which we will be slightly delayed, maybe about 5 to 8 minutes. Dr. Chang is just going to be driving up to his office because his home computer is not able to give the proper display for the Zoom call. And in the meantime, we will kind of have a discussion on PC rent, and all of us can kind of share our inputs. And if this is also a chance for people who've logged in to put in their queries, and we should be able to kind of have a interactive discussion for 5 to 10 minutes until Dr. Chang is able to log in. So I'll start with Arvind, Dr. Arvind from Hyderabad. What is your approach when you are confronted with the scenario of a PC dehiscence?
So thank you so very much, Rishi. So PCR is bound to happen if we are doing any surgery. So complications will be there, and in cataract surgery, it is the most commonly encountered complication. But if we go step by step manner, we can manage it quite nicely. And even in so many cases, we can put even the premium IOLs in the bag, or with the help of the optic capture, it is possible. So first, foremost thing is to plug. If once we notice that there is a PC rent, so we need to plug it with the help of the viscoelastic material, push it back, and try to make it regular, that PCR. That helps a lot. And use of the this Kinacot, it's very mandate. It's a mandate, so we need to do that anterior vitrectomy assisted by the Kinacot. And once we are free of any tags to prevent any further complication like the vitreous leading to the retinal detachment later on, and macular edema. So we need to do a very good anterior vitrectomy. If it is there, with the help of Kinacot, we are able to know. And then we can proceed with the next steps of like the IOL implantation. And in my 20 years of experience, most commonly it is during when we are doing the cortical aspiration. So what is your take, Dr. Rishi, being a very senior and prolific anterior segment surgeon?
So I think whenever we have a PC rent, first of all, we should be able to recognize it. So there are certain telltale signs, you'll get a pupillary snap sometimes. You may have difficulty if you're in the middle of nuclear fragmentation or phaco emulsification of the nuclear fragments. The fragments will not easily come into your port. If you're doing irrigation aspiration, you may start seeing the capsule moving with your movements of the instruments inside the eye, or things are just not seeming right. So whenever you have a doubt, essentially the first thing to do is kind of stop, assess the situation calmly. Don't pull out your instruments straight away. Put in a dispersive OVD if you can, before you pull out your phaco probe or irrigation aspiration probe from the eye. I find having an endoilluminator is a very useful tool to kind of see what's going on inside the eye. So I have an endoilluminator in my cataract OT, and I don't hesitate to use that probe. I put it inside the eye and look at the integrity of the PC, the zonules. You can even visualize vitreous if there's any. And if I have a doubt that there is vitreous indeed, I'll ensure that I have secured the nuclear or cortical remnants so that they don't kind of drop inside. and I will do a careful limited anterior vitrectomy. I usually prefer the limbal route, but I know a lot of people like to also go past vena, so either way is okay. The principle being that you should use a higher cut rate than an aspiration rate, and try to do your vitrectomy in the anterior vitreous, so that if any vitreous has prolapsed anteriorly, that will also be sucked back in. And you want to make sure that after you finish that vitrectomy, you make sure you can clearly see the outline of your PC dehiscence and see if there's any peaking on any side. If there's any peaking, that again tells you that it could be there could be some vitreous stuck there. So you want to release those kind of strands of vitreous. Then once you're sure, you can kind of sweep all your ports underneath your ports, so your main port and side ports, because vitreous tends to go out whichever sides there are openings. And if you see that nothing is kind of tugging over there, then this is the stage that I would actually put in triamcinolone and make sure there's no residual vitreous. And if there is, then I will kind of remove that from anterior to the posterior capsule. And at this stage, I will decide whether the capsule lorexis is needs an extension, an enlargement or conversion to a posterior capsulorhexis. So if it is possible, I will always try and convert the PC tear into a posterior capsulorhexis, but sometimes the tear may be too big to do that. But whenever possible, do that, because while maneuvers of implanting the lens, it can extend and you may lose the support that you need for implanting a posterior chamber lens. And at that stage, of course, once you have done that, you again make sure there's no vitreous and implant the lens. And I'm happy to say that Dr. David Chang has made it back. That is record time, I must say. And welcome back, Dr. Chang.
All right, thank you so much. Let me get
so
my.
I would like. Yes, I would like to welcome Dr. Chang to this International Ophthalmology Conclave of All India Ophthalmological Society. He's been a distinguished guest at many of our annual meetings, and he's a world-renowned cataract surgeon who's taught us so much over the years. I'll quickly introduce him, and we won't take away time from his masterclass. Dr. David F. Chang, MD, is a summa cum laude graduate of Harvard College and Harvard Medical School. He completed his ophthalmology residency at the University of California, San Francisco, where he achieved the rank of clinical professor in 1999. He is past president of ASCRS and past chair of the AAO Cataract Preferred Practice Pattern Panel, and served as chief medical editor of iWorld and Cataract and Refractive Surgery Today. Dr. Chang is past chair of the ACRS Foundation and has received the 2019 AAO Humanitarian Service Award. He also received the Energize Award for mentorship from the AAO Young Ophthalmologist Committee in 2025. He is co-founder and advisory board chair of iSustain. Dr. Chang has received honors from the following international organization: AAO Kelman Lecture, ASCRS Binkhorst Medal, Lindstrom Medal, and the Kelman Innovator Award, ESCRS the Ridley Medal, APACRS Lim Medal, UK ISCRS International Medal, the Rayner Medal, Ransco Greg Medal, APAO Jose Rizal International Medal, Miyako El Maghrabi International Award, and the ICO T. Croway's Gold Medal. Including these, he has delivered more than 70 named lectures. He holds the chair 11th in Academia Ophthalmologica Internationalis, 100 leading international academic ophthalmologists. In a poll of American ophthalmologists, Dr. Chang was voted #1 in Newsweek's 2025 list of top cataract surgeons in the United States. He was ranked #2 in 2024 Power List of 100 most influential ophthalmologists as selected by the ophthalmologists. Welcome, Dr. David Chang. It's an honor to learn from you. Thank you.
Oh, well, thank you very much, Rishi. I'm honored to be able to talk about posterior capsule rupture and to try to do an in-depth. Can you see my slides?
Yes, sir.
Yes, we can
Full
see.
screen.
All right. Thank you so much. Well, I have no financial interest in any particular thing I'm going to talk about. I do have 2 textbooks that are available online, and they cover a lot of the details of what we're going to try to cover today, showing sort of our top, let's see if I can get this. I'm not sure if having a little trouble with the video here. Oh boy. All right. So this is a posterior polar cataract, of course. And let's go through some of the basics. I'm suspecting a tear in the posterior capsule. So the first thing I'm going to do is go through the second side port instrument and fill the anterior chamber. I'm going to block that. And if I just move it right along here, you can kind of see the outline of the tear, and it's going from the bottom left to the upper right. So because I've blocked and filled the anterior chamber with viscoelastic, kept the pressure there, the vitreous does not prolapse forward. And so the question is, what's the best way to remove the cortex now? And so this is an example of where biaxial INA is helpful. You can see that, without there's no infusion sleeve. So I can reach all the way across the anterior chamber and immediately occlude the port with cortex, so that I don't aspirate vitreous, which we have an open posterior capsule. But the other thing I'm doing is I'm dissociating the irrigation and the aspiration. So instead of having to point the irrigation behind the plane of the iris in order to get the cortex, I can keep the irrigation in the anterior chamber while my aspiration is underneath the anterior capsule. So that ability to dissociate is very critical here when I have an open capsule. So that is why I'm not aiming the infusion flow toward the rent, where I could, basically rupture the hyaloid face and encourage vitreous to move forward. So that ability to dissociate infusion and aspiration is critical. See, I can reach way across there without the sleeve. Now, I have to switch hands, so the same thing has to happen. I have to inject viscoelastic. I then stop the irrigation, let the viscoelastic accumulate, then I can switch hands. And of course, that's the other advantage of biaxial INA, is I can access the subincisional cortex, as you're seeing here. So this is something that you should be familiar with. Just do it on routine cases so you're used to the instrumentation and so forth, because it really comes in handy in a case like this where I have an open capsule, but the hyaloid face has not ruptured. So once again, before I come out, every time I have to make sure that I don't allow the chamber to shallow by injecting a viscoelastic. Now here I'm injecting a dispersive because it stays where you put it. And then you can see the anatomy much better now. So this sets me up, in this case, for a 3-piece monofocal that I can put in the sulcus with optic capture. If I had a 1-piece IOL and I needed that because it was, maybe an EDOF optic, you could do reverse optic capture. But of course, a 3-piece monofocal in the sulcus works beautifully here. And then you saw me push down each time, and there I'll have the overlapping rhexis. I do not have to aspirate the viscoelastic behind the lens because it will diffuse into the posterior segment and it get absorbed there, and it will not cause an IOP rise. And you can see it also is safer now because I basically plugged the opening in the posterior capsule with the IOL, so I can safely aspirate the viscoelastic in the anterior chamber. Now, this is another posterior polar cataract, and this is just showing an automated capsulotomy called Zepto. Now, a word about posterior polar cataracts. We all agree that we're not going to hydrodissect, we're going to hydrodelineate. I, in addition, do my best to not rotate the nucleus. So I'm going to try to chop in situ and not rotate, because when you rotate the nucleus, you have to push against the capsular bag. And in doing so, this is viscodissection to sort of separate the peripheral epinucleus from the capsule. But then you're going to sit, and there's the hydrodelineation. So then I'm just going to make my chop. And this is such a soft nucleus, it's easy to do. But think about trying to chop a couple of different directions to create a little pie-shaped fragment. And then I will simply, pull up the epinucleus and try not to rotate the nucleus. In spite of this, you're going to see that as I get a better view, I'm going to start to see little bits of lens fragments in Berger's space. And once that happens, so here again, I know that the posterior capsule is hopefully intact, but I don't want the chamber to shallow, especially in a younger patient without a lot of scleral rigidity. So you saw me use viscoelastic to pressurize the anterior chamber through my side port. Now, at this point, I can start to see lens material behind the posterior capsule. So I know I might be in trouble. That's okay. I have control of the anterior chamber. I'm going to remove the cortex here. But again, I'm not going to abruptly withdraw my INA tip without first injecting viscoelastic through the side port. I always make my left-hand side port at the 45-degree angle. Here you can see a little blood there, but sometimes you don't have that. And when you need to find that port, if you're consistent and you make your left-hand side port right at 45 degrees, it makes it a little bit easier to find every time. So now that I got the cortex, because I have the pressure on, and that I would not turn the infusion down, the irrigation down. I don't lower the bottle. So here I'm protecting that because you don't want to lose infusion pressure. Now you can see the rent. You can actually see the posterior polar cataract, the little white fibrotic particle there. So I need to put in a high power toric lens in this patient. So how am I going to do that? Because I know I need to rotate the lens to get it on the correct axis, and I don't want that to split outward. So this is the posterior capsulorhexis technique. These are forceps that I'm introducing through the side port. They're made by Microsurgical Technologies, or MST. They're actually Barry Seibel's forceps. And I have to use the Brian Little tear-out rescue maneuver because the posterior capsule is so thin and elastic. But the advantage of these forceps is I can bring them through the side port. I don't have to manipulate through the incision, because that'll cause me to lose viscoelastic through the incision. I'll shallow the chamber, and then, of course, then the hyaloid face may rupture. And so here, it doesn't matter what size it is, I just want to round the edges off. And now I have converted that tear into a posterior CCC. And so this will allow me to then sort of preserve the structure of the capsular bag. So here's that high power monofocal toric. It is a T5. It's with the rule. So I just have to make sure that the lead haptic goes in between the anterior and posterior capsule. But this is the part that I was concerned about. I need to be able to rotate it to get that T5 on axis. And the posterior CCC resists tearing and allows me to do that. So it's worth giving it a try. Of course, I could have put a 3-piece in the sulcus and manage the astigmatism in other ways. But this is a demonstration of the benefit of the posterior CCC. All right. Now, what about if there's nucleus still in the in the eye when you have a posterior capsule tear. Well, first of all, we need to discuss when am I going to convert to an extra cap. We all have our own indications. These are some of mine, but it's something you always have to have thought out in advance, done some mental rehearsal. Under what circumstances do I want to convert to an extra cap? And the way that I might do this under topical, if the patient, you can do it under topical, but if the patient's wide awake and maybe sort of sensitive, you can give a subtenon's a xylocaine block. I've abandoned my temporal clear-corneal incision and I move superiorly. If you have a small rhexis or you can convert it to a can opener, and you're going to use a lens loop typically if you're afraid of a zonular dialysis or a posterior capsule rupture, and don't try to be too stingy with the incision. All right. So here are two cases where I have very dense nuclei. On the bottom one, it's IFUS, and I already have iris prolapse. On the upper one, look at how the entire lens is moving when I'm doing my CCC. So I've already converted on the bottom case. I just decided with that brown lens and iris prolapse already. And then on the upper case, wow, I'm seeing so much movement that I am going to convert. So both of these are converted, and you'll see two different methods. On the bottom, I'm doing the manual small incision cataract technique, popularized in many places, but certainly at Aravind, where I'm going to have a scleral pocket where the dimensions are wider internally than they are externally. And up above, I'm just going to not worry about it. I'm just going to do a traditional limbal incision that will require more sutures, but I can do very, very quickly. And in either case, I haven't lost vitreous. I have, basically just done the capsulotomy. So it's not that different from doing the extra cap from the beginning. And the temporal clear corneal incision can be abandoned because it's self-sealing. So here you see the bimanual expression. You can see that it takes me longer when I do the scleral pocket to create that. So there's a little more time there. But I think this is something that we don't do enough. Certainly here in the United States, where many of the current generation of cataract surgeons don't have experience with this. We don't have the same density population of really dense cataracts that you do in India. And so people just do phaco on everything. And the advantages of the extra cap for cases, high risk cases like this, is you're going to preserve more endothelial cells. And certainly it's the patient's advantage if we can preserve the posterior capsule and not have to do a vitrectomy. In both cases, I'm putting in a 3-piece monofocal. Now on the top, I am using the temporal clear corneal incision to remove the cortex, and on the bottom I just put in one suture myself, and that's enough there. And so both of these cases now have an intact posterior capsule, and that's the advantage. All right. Now, what if we're a little further along? These are some older cases. What are the signs when you're doing phaco that you've got a problem? One would be if the nucleus is tilting. So in this older video, right now I can tell something's wrong because the left-hand side of the nucleus is tilting back. You can't see that in the 2D, and there's a lot of mobility of the whole nucleus. So rather than trying to proceed, I move superiorly, abandon my temporal clear corneal incision. This is just a lens loop now because I'm afraid of a zonular dialysis, so I cannot do the bimanual expression that you saw in the previous two cases, and I just want to go in and extract that lens. So even though I'm not sure, if I suspect that I might have posterior capsule rupture, and it turns out that I did, you have to make this decision early. And here's another case where I said, let me go ahead and try to do the phaco. It's a really rock hard lens. And some of the other signs are just that there's an excessive lateral mobility of the lens. So in this case, I'm not seeing the entire capsular bag move, but I'm just feeling like there's more. I'm still okay here, so I'm going to remove that. But in a moment, it's like the entire lens is too mobile, and it's actually displacing to the left too much. And I said, this is not right. I must have maybe a zonular dialysis. So this is the critical point, because it's so tempting to just continue. Maybe I'll be okay. And I've got to assume that there's a good chance I got a dialysis. So I'm going to prolapse the nucleus into the anterior chamber, go superiorly, take out that one of the iris retractors, and let's just get the nucleus out, and then we'll see what we've got. We temporarily closed the incision. I ended up doing a vitrectomy, putting in an anterior chamber lens. So those are two cases where I guessed correctly and I stopped early. Let's look at this traumatic cataract in a young patient. I'm immediately going to put a dispersive viscoelastic in to block that opening, and the dispersive stays where you put it. And we know there's trauma because of the truncated lens fornix. It turns out that iris hooks are about the right length to support the capsule. The dedicated capsule retractors would be too long. And here again, I keep trying to create a wall of dispersive viscoelastic in that area. I mentioned the benefit of biaxial INA before. I can keep my irrigation away from that zonular defect. And now I'm blocking the anterior chamber with viscoelastic, and I'm going to put the CTR in. And the CTR makes the anatomy look so much better that I'm thinking, well, I can put this lens in the bag now, only to discover as I do this that the entire lens is tipping downward away from me because there are no zonules. So I realize that now I cannot pull the lens back into the injector, but I'm going to quickly pivot and get that lead haptic out of the bag and instead put that lead haptic into the sulcus. And I'm going to orient the haptics 90 degrees away from the zonular defect and capture the optic and say, well, we're in great shape. But look how I don't see the CTR now. It's underneath the iris. But as I remove the viscoelastic, I start to see the CTR. And this is a bad sign. Like right here, look, I can see the CTR. So I said, maybe I don't trust this. And I have such a big pupil that I can see this. So I'm going to put the viscoelastic back. And now what do I do? The lens is centered beautifully. It looks fine. Let's see what happens if we put in some Myocol. And as you'll see here, it's still kind of hung up there. It doesn't quite come down. So what would you do in this case? We've done such a nice job. The lens is perfect. Can we leave the case this way? Sometimes you just wish you had someone wise in the operating room with you to ask. In San Francisco, one of our famous people is Inspector Harry Callahan. So let's see what he has to say.
We can't hear the audio, Dr. Chang.
Okay, no problem. That's okay. The question is, do I feel lucky? And I couldn't. So let's put in the triamcinolone. And the reason this is one of my favorite teaching cases, as I doubt that any of you, or I certainly didn't think that there would be this much vitreous prolapsing already through that rent. So it just goes to show you how, without being able to visualize the vitreous, we just cannot see that. All right, let's take another case here. This was a Flomax case. You can see the iris retractors. And the reason I turned the video on and I'm stopping here is while I was doing the chopping, I suddenly saw the pupil widen and the chamber deepen. It just abruptly deepened. And I didn't like that, so I stopped. And the question is what to do. And again, it's so tempting to continue on with the phaco. All right. Now, when we have posterior capsule rupture, and we still have the nucleus present, as in this case, we've got some challenges. Okay, we got the small pupil. Sometimes the rexus, as a result, is very small diameter. We may have multiple fragments, and we have to do our best to somehow keep this nucleus from descending. So this is the picture that I have to be imagining when I saw that chamber suddenly deepen. That's a sign that there might be probably posterior capsule rupture. And when viewed from above, and you don't see this anatomy, you're just thinking, well, maybe I should just be able to continue with the phaco. But think about it now. If the posterior capsule is open, when I aim my phaco tip toward the remaining fragments, I'm directing the infusion in that same direction, like a hose. And if I start infusing right toward the opening, what's it going to do? The flow will pass into the posterior segment. It's going to rupture the hyaloid face. It's going to propel vitreous forward. The rent is going to widen, and the next thing you know, if I'm going to find that the pieces, because the posterior capsule is not fully intact, the pieces are going to move away from me, and that my instinct might be to follow and chase the piece and then buzz into it a little bit to try to grasp that little bit of a fragment. So it's so easy, it's so tempting to do this, but if you imagine this picture, and that's why we're spending time on this, you will know that that's a bad idea. So you have to resist the instinct to just continue with the phaco. Our instincts are developed from cases where the capsule's intact. And we aim the phaco tip downward, right at the piece, we buzz into it, and we're fine because the posterior capsule holds the vitreous back. But if I don't have an intact posterior capsule, I may end up aspirating vitreous, and that is literally the worst thing you can do with the phaco tip, because that's going to cause a giant retinal tear. And even though a good vitreoretinal surgeon can fix that RD, you have maybe a 50% chance of PVR when you have a giant retinal tear. So what should we do instead? Well, this is a technique that Richard Packard and I published. And the first thing is you go through the pars plana with the viscoelastic cannula, and we're going to just sort of try to push vitreous back and sort of get underneath the lens material. And then we're using the cannula, not the viscoelastic, but the cannula to levitate the pieces up. This is the so-called posterior assisted levitation. It was really first popularized by Charlie Kelman using a cyclodialysis spatula. And we simply said, use a viscoelastic cannula, something dispersive like a viscote or Helan Endocote. Viscote has a smaller cannula, so that you have the added advantage of sort of creating a barrier of dispersive OVD. Now, the anterior vitrectomy, and I think a lot of you know the principles. We have to have a high cut rate because we want to minimize vitreous traction. We have to always be able to see the cutting port. That means we can't go too peripheral, where it's hidden by the iris, and we can't go too posterior, beyond which we can focus our microscope. You want to split the infusion, and you can see here I just have a self-retaining limbal infusion. Amar Agarwal has the Trocar AC maintainer. You could go through the pars plana, but most of us aren't that familiar with that. And in an eye that's soft, and an eye that you're already worried about PC rupture, probably best not to do that. So just have a self-retaining limbal cannula. You have to know how to set up the vitrector, and it's simply a setting on your monitor. So irrigation cut aspirate is how you remove vitreous. But if I want to then use the vitrectomy tip to aspirate cortex or lens material, I switch it to irrigation through the pars plana. A limbal incision is also a possibility, but I'm going through the pars plana. How far back do you go? If I'm coming in at this angle, where I'm angling the tip toward maybe where the back of the lens normally would be. I go 3.5 millimeters back is where I make my scleral incision. If you go parallel to the sclera, you go 3 millimeters back because you're basically wanting to enter in the pars plana. But if I'm coming in more tangentially because I don't want to, enter too anteriorly, I'll start 3.5 millimeters back in terms of that. When I first learned vitrectomy as a resident, we just stuck it in the phaco incision. Boy, that's bad. You have this bad angle of approach because you still have to pass through the pupil and the capsulotomy. You have a leaky incision, so now you have an unstable anterior chamber. And you're pulling vitreous into the anterior chamber, both the vitrector and the vitreous leaking out through the incision. And all of the viscoelastic that I put in the anterior chamber gets aspirated. So if you have no posterior capsule, no vitreous, no viscoelastic in the anterior chamber, what is going to happen to the nuclear pieces? Yeah, they're all going to drop. And spiraling, domino effect of losing your nucleus. So instead, this is an approach that I've talked about in my courses and my textbook, and go through the pars plana, or now I have or the limbus, because you want a tighter incision, and you split your irrigation, your aspiration. You want a stable anterior chamber. I like the pars plana. Not everyone will be comfortable with that, and it's not to say you can't go through the limbus, but you get a posterior angle of approach. You get better access to the vitreous. You're pulling the vitreous out of the anterior chamber, away from the incision, back toward the posterior segment. If you fill the anterior chamber with viscoelastic, as in this diagram you can see with the yellow, what I've basically done is I have created a separate compartment filled with viscoelastic that is trapping the nuclear fragments, the epinucleus and the cortex, in the anterior chamber. And then I work in a different compartment behind the iris, behind the anterior capsule, dealing with the vitreous. And I call this the viscoelastic trap, because I'm using the viscoelastic to trap the material so that I can do a proper vitrectomy and yet not have everything descend. So this is a key concept. That's why we're spending a lot of time on it. Let me just say at the outset that if you're not comfortable with any of these things, it is perfectly fine if the fragments drop, because we have wonderful vitreoretinal surgeons that can do a great job of taking this out. In private practice in the United States, I don't have a vitreoretinal surgeon in the next operating room, so I have to refer the patient. And if you do that in a timely way, the patient will do fine. So do not feel the pressure to do something you're not comfortable with. But this is an advanced course, so I'm going to tell you what the principles are and how I will sometimes apply them. But I certainly am not going to chase after pieces. You can't violate some of the principles that we have talked about. All right, so now here's the viscoelastic trap, right? We've come through the pars plana. You could go through the limbus, but the idea is you don't just push the pieces up with viscoelastic, you fill the anterior chamber. Well, what about the vitreous? Well, I've drawn it here schematically because you can't see it, but you just have to assume that there's vitreous that is prolapsing forward into the anterior chamber. But you can cut it. You introduce the vitrector through the pars plana, and you stay below the plane of the anterior capsule. And if you systematically cut systematically across the diameter of the pupil, you will effectively cut back any vitreous, even though you can't see it. I'm not a big fan of using triamcinolone at this point because I just can't see anything. It's like working in a snowstorm. So I just rely on the other clues and the fact that if I do a real thorough anterior vitrectomy now, it's a pars plana incision, but it's an anterior vitrectomy, then I can cut things back. Now, once I feel I've done that anterior vitrectomy, I can go back and deal with the lens fragments. And I can do that with the safety of not having vitreous in the anterior chamber to get aspirated by my aspirating instruments. Okay. Now, controversial. What about this pars plana thing? Well, remember, this is not a posterior vitrectomy, it's an anterior vitrectomy using an incision through the pars plana. I mentioned we're not doing a 3-port posterior segment vitrectomy with an infusion cannula through the pars plana. So if we go through the limbus, we're well familiar with that. There you see the limbal self-retaining cannula up top. What about the idea of getting retinal breaks at the sclerotomy? Of course, that's possible, but we don't need to make a really tight incision because we're not trying to pressurize the eye with high infusion. So we're just trying to have access with the vitrectomy. So we're going to use, in my case, an MVR blade and not make this too tight. You can do it even under topical, but you can do the subtenons. And what about the greater risk of retinal complications? Well, I think that's already happened because we've had PCR and done a vitrectomy, and that patient needs to be monitored carefully, regardless of the incision that I make for my anterior vitrectomy. All right, so let's go back to that first case where I left off. You remember? Traumatic zonular dialysis. So I got to be able to see. But here I said I'm going to go 3.5 millimeters back because I'm aiming tangential. I'm not perpendicular to the scleral surface. And there's my MVR blade. And it doesn't have to be a tight incision. Now look at the vitreous in the anterior chamber. The cutter is behind the IOL. But all that vitreous that filled literally the anterior chamber, I'm pulling it back through the defect into the vitrector. And I can see where it is. And that's the beauty of the posterior approach. Because if I was coming from the limbus, as I pull vitreous forward, and I'm going to close this with an interrupted atovicral suture. If I came through the limbus as I pull vitreous forward, well, the defect, zonular defect, acts like a one-way valve, and it traps the vitreous, and it doesn't fall back. So that's the benefit of that posterior approach. All right, remember this case. I stopped, and I was tempted to go forward, but I got to think, hey, when the anterior chamber suddenly deepens, that's usually a sign of posterior capsule rupture. So remember what we said. You can abandon the temporal clear corneal approach. I have repositioned the microscope, and here, 3.5 millimeters back. Now, I have no certainty that the posterior capsule is ruptured, but that sudden deepening of the chamber has told me that. And now this is the PAL, posterior assisted levitation. And I'm not going back into the mid-vitreous and fishing for the nucleus. I'm just propping this nucleus up in front of the iris so that I can get it out. I'm going to remove the superior iris retractor, take down the conj, and again, you can do this even under topical or inject a little bit of lidocaine subconjunctival. Now I'm going to convert to my larger incision. There we go. And I cannot do bimanual expression. I've got to use a lens loop because I suspect there might be a posterior capsule. And if I press with bimanual pressure, the path of least resistance may be posteriorly. Now, I'm finding resistance, so do not squeeze and push the lens against the endothelium. You have to go back and make the incision a little bit larger. The size of the incision is the least of this patient's worries right now. And okay, finally I can deliver this. And there we go. Now there's a lot of cortex and epinucleus, and I don't want to fish for it, and I don't want to burp it all out because that would mean I'm burping out a huge amount of vitreous at the same time. So this is the viscope trap. Remember, dispersive viscoelastic filling the anterior chamber so that it is going to support the lens material. So I don't feel I have to kind of go for it now when I've got a mixture of lens material and vitreous in the anterior chamber. Now, when I do my pars plana approach anterior vitrectomy, look at how the cortical epinuclear material doesn't move. It's frozen, showing you that I have trapped it with the dispersive. And that's the key. And I'm just trying to systematically do my anterior vitrectomy behind there. The visibility isn't great. So I'm going to go back here, do a little bit more with my viscoelastic trap, moving things forward. Okay, and then I can now do my biaxial INA. So I'm going to remove some of this epinucleus here. I've got my infusion already, so I use my second hand to move to mash the material into the port. And then I remove a little bit more. Here's that viscoelastic pal. Again, the pars plana is giving me a little bit of a better approach. I could go through the limbus here, and now I do another round of vitrectomy because I can see better, and I just keep cutting this back. So the principles are you have to manage the vitreous before you start aspirating lens material, but the viscoelastic trapping the nucleus keeps it up in the anterior chamber or anterior segment so that it doesn't descend. And it gives me a much better chance of getting all the vitreous itself out of the eye. All right, so here we are doing the final steps here. The lens implant is a whole nother topic that we're not going to spend a lot of time on. But look at the size of my incision. And I have a lot of experience with anterior chamber lenses, and there is just no reason we have to do a lot of suturing here. We've been in the eye a long time. We've got a big incision. I'd like to close it. So I just slip in an anterior chamber lens. If they're properly sized, they do beautifully. You do have to do a peripheral iridectomy, and there's my incision. But again, this patient, we did not have any retained lens material. They did fine. They did fine with the anterior chamber lens. I use an 8-0 resorbing vicryl interrupted suture to close the pars plana incision. And there you see the nucleus that we successfully got out. Okay, here's another case. This is a case where it's a one-eyed patient, and I am chopping this ultrabrunescent nucleus. I got most of it out, and I see I've got a posterior capsule rent. So, this is so, demoralizing. So what I'm going to do is I have gone in. Let's see here. So, and I have to go through the second port at 45 degrees, and I'm going to inject viscoelastic so that I can remove my phaco tip. That wasn't a dispersive, but I reached for dispersive. Now I've got dispersive OVD, and I'm using this cannula tip through the limbus now because there aren't that many pieces to levitate them into the anterior chamber, and I need to fill the anterior chamber with a dispersive OVD. All right, so now I've got to deal with the vitreous. This is a little different than the last case, isn't it? So I'm going to go, this time 3 millimeters back, I'm going to go a little more perpendicular to the sclera. You just want the internal opening to be at the same place. And now I'm going to go with that viscoelastic PAL because that piece is mobile. Can you shut the door, please? And I'm going to levitate that last fragment into the anterior chamber so that everything is stable. Now when I do my pars plana anterior vitrectomy, again, see how all the material in the anterior chamber isn't moving? It's because it's suspended, perfectly well suspended with the dispersive OVD. It's trapped. It cannot go anywhere. And we're moving systematically. Got a big pupil, so I got to systematically do this. I turn the port facing posteriorly, so I have removed any and as much vitreous as possible. I cut the vitreous back, and then I have these pieces here. Now, the last case, I had that huge nucleus, so I converted to a manual extra cap. This is an opportunity, though, to use the IOL as a scaffold, a three-piece placed in the sulcus, because I know I have an intact CCC, so I know I can put this entire lens in the sulcus. This has, of course, been popularized by Amar Agarwal, and I rotate that three-piece. I got the nice intact rexus, and now I have my artificial posterior capsule. It's going to, now I still have to do the vitrectomy. So you see the pars plana approach where I'm going through. I have to make sure I cut vitreous back because we don't want anything to sneak around the edge of the IOL into the phaco tip. But I have the security, and then I line up all the pieces so they're centralized right over the center. I'm going to use my lowest vacuum setting, like my epinuclear setting for this. And you don't need, you do need irrigation, but you just want a low aspiration flow and aspiration vacuum. So it's really slow motion. The IOL serves as a shield to block vitreous from coming toward the phaco tip, and it obviously keeps the nuclear pieces from falling posteriorly. It creates a floor. Now, I got to be careful when the pieces go peripherally. And for a moment, this is going so well, I just get, I'm ready to sort of chase this piece. And I got to realize, wait a minute, I don't have a posterior capsule here. So I've got to come out and I've got to take another moment to maneuver this over the IOL optic. There we go. And then I go back in now with my phaco tip and I remove that final fragment there. All right. So last round. So again, the nice thing here is because I have the pars plana, any vitreous that's there, I'm cutting it back. Look, there's a little strand that kind of came up toward the incision. So I found that here. I'm going through the limbus using the vitrector like a spatula. And of course, the last thing is to make sure that the haptics are truly in the sulcus. And then because I have an intact rexus, I can capture the optic with the CCC, meaning I don't have to adjust the power. And last step now, I put in the triamcinolone because I don't lose visualization for the other key steps, but I can just be absolutely sure that we're not left with any strand here. And then it's always a good idea to put in Myocol as well to block vitreous from coming forward, and as another way to tell if you've got any peaking of the pupil, such as through vitreous prolapse. So here, this is a smaller cutter. And then again, I like Adovicryl to close them. I think we have time for one more case. So let me show that. Very significant dense cataract with pseudoexfoliation. The pupils coming down. Okay, I get through all of that. I get this big plaque there. Here's the piece under the iris. So let me just maneuver my phaco tip. Oh, wow. Look what happened. I didn't have enough protection. The posterior capsule flew up because it wasn't taut. And as I tried to get that last piece, this is what's happened. I now have a rent in the posterior capsule. So same thing. I still have that fragment there, and I have to resist the temptation to go aspirated. So what do? I maneuver it out of the bag, but I might have this. And if I have this, I can't go out after and just phaco that brunescent nucleus. So instead, I have got to address the vitreous first. So now I'm going to park that on top of the iris, trying to see if I have any other nuclear fragments under the pupil there. I'm going to go through the pars plana, 3.5 millimeters back. It's tangential. And then I have to do this maneuver again where I'm cutting with the cutter through the pars plana. It's still an anterior vitrectomy. I'm turning the port away from the posterior capsule because I don't want to accidentally cut the iris or the anterior capsule, which I want to use to support my IOL. And then I'm going to put viscoelastic And here goes the viscoelastic is to, widen the space in the sulcus between the anterior capsule and the iris. And here goes the IOL. Now, here's a case where I'm not quite sure if my anterior capsule is intact. I'm not sure I have a full CCC. The pupil being small is part of the problem. So just to be sure, I'm going to leave one haptic of the IOL out the incisions, just so I don't want to drop the IOL. So you can use it as a scaffold here. You'll see that, one of the disadvantages, the optic wants to decenter, and it wants to, but slowly but surely I am attacking that last piece, but I'm doing it with the IOL. You see everything's kind of shallowing here. You see how the lens is moving to the side because of that one haptic there. So I keep trying to put that optic back into place so it doesn't look as elegant, but it did the job. And, I basically got that last fragment out without things falling. There is some cortex there. So this is the point at which I need to widen things with the iris retractors. And perhaps I should have done that earlier when I was going to phaco that last piece. But on the other hand, the iris itself was part of my barrier to that piece falling posterior. So that's kind of why it was nice to have a smaller pupil. But now that I have to do my final cleanup, remove the cortex, I need to see, so I have to put that in. And lo and behold, I do have an intact capsular rhexis. I wasn't sure. So that means I can simply dial this in. And even though the rhexis is a little bit on the small side, I'm going to succeed at capturing it here. So there I've captured it. And now we can let the pupil come down and put in the Maya call. So we got that last piece out. We did the vitrectomy, and this patient did fine as well there. Let's talk about a couple of things. I think it helps to take the instruments that you might need in this situation and kind of put them all together, because this is always unplanned. And, the nurses have to set up the vitrector, they have to set up the settings, and then you want all of these things that you're not normally using, a lens loop, corneoscleral scissors, perhaps bimanual INA. So we kind of package them all together and put them in one kit. A couple of things that we've emphasized. You do not want to chase the nucleus. If you suspect PCR, you have to do all the steps we said. And I've thought about this. Why is it that we do things that are naughty, that we know better, that we shouldn't do, but it's our instinct? And I think one of the things is we all have this unspoken fear of, what are we going to tell the patient? And we're thinking about how upset the patient is that surgery didn't go right. I still have lens in my eye. I'm going to have to see a vitreoretinal surgeon. So, we kind of are tempted then to try to make things right by chasing the nucleus, and maybe if I can just get that last piece out and put the lens in, I'll still tell the patient there was a complication, but it's good, you're going to do fine. That's the temptation. But remember, when you're in this situation, you point your phaco tip posteriorly, the irrigation is going to expand the rent. It's going to propel the nucleus backward, and this is the worst thing you can do, is aspirate vitreous with the phaco tip and activate ultrasound. So I think that we would have less of a fear if we all kind of spent more time. And so those of us that are experienced surgeons have already done this. We've already learned this. But for our early career surgeons, this is kind of a fear of, well, what am I going to say? How am I going to react? These are my pearls for counseling. You have to be patient. You have to be empathetic. But I think it really is important to be reassuring, because, you're not going to go blind. You're not going to lose the eye. You have to make this understandable. And you have to acknowledge that this is really annoying. There's a lot of anxiety. There's a lot of inconvenience. And, I think that's what the patient will feel better is that you understand what they're going through. And, so the way that I would do this is you've just spent an extra half an hour dealing with this situation. You're behind schedule. You're kind of flustered. That's not the best time to have this conversation. The patient's being wheeled out in the post-op area. They have a lot of versed. They're not going to remember half of what you say. So I usually tell them to bring the family by the bedside. I go do the next case. I kind of regain my composure. I go out in the post-op area and I tell the patient, um, this was more difficult because of whatever reason, but we handled it well. And I think you're going to do fine. But as a precaution, I would like to have you come back to my office late this afternoon so I can just check your pressure. It's purely a precaution. And that's when you have this discussion, because now the sedation has worn off. They're ready and able to listen to you. And that's the best time to do it. You don't apology, I think, is important. You're not apologizing that you messed up, but you're saying, I'm really sorry. I know that this has got to be incredibly disappointing and frightening to you, and I really apologize that you're having to go through this, and especially there's going to be more inconvenience because you're going to need another procedure. The way that and so you do apologize for that, and then you explain what happens next. For posterior capsule rupture, that's a term we use, PCR. I think it helps to call it, I tell the patient the capsule around the lens that we use to hold the artificial lens is very thin and delicate, and it can split. And in your case, it did. So I use the word split, not rupture. And sometimes I'll explain this, that, with the eye surgery, you may think the eye is so small, but we have two viewing systems. Those of us that operate in the front half of the eye, that's cornea, glaucoma, cataract, refractive. We have a microscope that focuses on the front half of the eye. Surgeons that operate on the retina, vitreoretinal specialists, their microscope setup, they focus on the back half of the eye. And so we have a different setup. And so when the capsule split and one section of the nucleus of your lens, was only about 1/6, but it fell through back to, and it dropped to the back half of the eye. And surgeons are often tempted to try to go after it, but the problem is that the microscope doesn't focus far enough back and we don't see it very well. And so for that reason, I always have to think, what would I want if I was the patient? And if I was the patient, I wouldn't want the doctor to take that chance. I'd feel better, it's safer if we just come back on another day to see the vitreoretinal surgeon using the better microscope setup to get that last piece. And it's only about 1/6 of the cataract is left, but it's just safer that way. When you tell the patient, I thought about what I would want if I was in your position, they're not going to criticize or be upset with you. They may be upset, but they're not going to be upset with you. I think you can be optimistic about the prognosis, because truly you can. And, it's kind of like when you travel in the airplane, this is a complication, but it doesn't mean the plane crashed and all the passengers died. It means that you missed a connection. You have to spend the night in the airport. It's awfully inconvenient. I acknowledge and I apologize for this inconvenience. I'm not apologizing for the mechanical delay or the weather delay. That wasn't my fault. I'm apologizing that you have to go through that. So these are the principles we've covered today. Avoid aspirating the vitreous. These are the things. I don't think it's important whatever lens you're comfortable with, AC, PC, IOL, and a timely referral is there. So thank you very much. I know we have a few minutes for discussion. I appreciate the chance to have a full hour to present what I consider my best teaching videos to go through this in a lot of detail. Thank you very much.
Thank you, Dr. Chang. That was an amazing masterclass, and I think all of us in this have learned so much, and people will continue to look at this video later and keep learning from it. Thank you. Before I ask my panelists, I have a question for you myself. I noticed that you're using a 23 gauge vitrectomy for pars plana, but you're still doing a peritomy and you sutured it. Any particular reason why you didn't do a sutureless, and why did you do the peritomy when you could have gone transconjunctivally?
Yeah, no, that's a really excellent question, and I think it all again depends on the level of comfort with surgeons. You know, putting a trocar through also works great. Um, some of these were older videos. You know, I started doing this when no one was doing it, and we didn't have a lot of these techniques. But I really do like to sort of gear this to people that have never gone through the pars plana, and that's a lot of people. This might be the first time, and it may be something you choose not to do. But an MVR blade is disposable. You can get a box of 6 disposable ones. You just need to have the right size for your vitrectomy cutter. Nowadays, we have smaller gauge vitrectors that work very nicely. But the point is, it doesn't have to be tight. It doesn't have to be elegant. You know, you can just take it down, make your incision, and get in and focus on that. If it was an elective case and you've got the chance to think it all through and so forth, absolutely, that's the best time to learn. But this is not the time to learn how to do a trocar, you know, through the pars plana. But it's a very good point.
I'd like to ask my panelists if they have any questions for Dr. Chang. Dr. Bhasin?
Yeah, thank you, Dr. Chang, for the beautiful depiction of variety of cases which you have shown to us. I'm really impressed, and many things you have discussed in detail, and most important is the management of new species and our trace. So I just want to know, my
I think there's some audio issue with Dr. Bhasin. Perhaps, Arvind, do you have any questions or comment to make? And then we
Yeah,
can come
of course, of course. So excellent presentation. I think, Bhasin sir, kindly switch off your video. Kindly switch
Arvind,
off
you can
your video.
continue.
Yeah, yeah. May I continue, Rishi?
Yes, yes.
So excellent videos and presentation, Dr. David Chang, and namaste, all the way from Hyderabad, India. So now coming to your, you have excellently managed all the cases. So in case the role of the OCT, if the pre-existing this PCR is present. Yeah, in pre-operative, yeah, and also intraoperative this dynamic OCT. So any experience with that, sir?
Yeah, no, I don't even have an OCT because our setup, we're only doing intersegment surgery. I mean, if you have it, I think it's nice. There's some beautiful videos that many of your colleagues have shown with that for posterior polar cataracts and so forth. I think a lot of the situations, though, that I showed, you know, it'd be really hard because you've got ultra brunescent cataracts. The lens is partly chopped. I still think there's no magic way to diagnose it. I wish there was. And what I think is really important is to have those instincts and that suspicion. And a lot of the benefit of going through this in such detail, and that's why I appreciate the time rather than in 8 minutes, is I want people to understand how I think. And it's just doing this today, and I applaud the audience for spending the time to do this. We get to mentally rehearse what the steps are. So I know exactly what the steps are I have to do. I can have confidence that I can do it when I need to, so that then when I suspect something, my immediate response isn't denial, and I don't want to deal with all this other stuff, and I don't know what to do, and I'm afraid. I'm just going to plow ahead with denial. And so I appreciate your question. It's a very good one. And I again, there's some really nice videos out there, but I think for so many of us, we're just not in a situation to deal with that. And so it's the suspicion that something's wrong and then converting to it and not just going down the same path.
Yeah,
Is
sir.
Dr. Prafula Maharana there? Dr. Basin, is your audio better now? Can you try again? I think they're both not very good signal. I'll ask another question to Dr. Chang. We've been taught about triamcinolone assisted vitrectomy, but I noticed that you're actually putting in triamcinolone more towards the end to make sure there's no residual vitreous in the anterior chamber. And because primarily you're using a dispersive OVD to kind of segment your nuclear fragments away from the vitreous. So is that, have I understood correctly, or do you use triamcinolone?
So I think that triamcinolone is such a great tool, right? Because it's visualizing it. So that's why I showed the one case where it looked like you were done with the surgery and you're just ready to leave the operating room and take your victory lap, and the triamcinolone really showed it. But it's a different matter when you have when you have nucleus in the eye, because now you're filling the eye with viscoelastic. And when you mix the triamcinolone, you're not going to be able to see. And triamcinolone means you have to inject a lot and then wash it out and see what's left behind that's been stained with that. So I'm glad you mentioned this, because I perhaps wasn't as clear as I could have been. I don't think it works as well when you're just trying to manage all the nucleus. So my focus in some of those cases was on the lens material and creating a bubble of viscoelastic safely around it, working as I know where the vitreous is. And then I use the triamcinolone at the end when the nucleus is gone and the viscoelastic is gone to make sure that I'm not leaving the operating room with a strand of vitreous that's up caught in the incision. So I use it sort of as the final check. So very good question.
I do exactly the same, and I'm so happy to hear this from you, because we keep hearing about triamcinolone assisted vitrectomy, but the first thing is to put a dispersive OVD, and with that, if you put triamcinolone, it just doesn't work.
You can't see.
Yes, you can see. Dr. Basin is back. Do you have any comments?
Actually, it was very good presentation, and diluted triamcinolone is really helpful. We just dilute it, and then we use, and then it will stain the vitreous. The concentrated triamcinolone is really not helpful. And Dr. Chang, it was very nice a talk which you have given and variety of cases. Can you just tell us when will you enlarge the section and which condition, and when you will proceed with the phaco?
Yes, that's a very important point. When you have a fairly large amount of nucleus, and that was that case with the Flomax with that large nucleus, no, you don't want to be phacoing there. You want to get the incision large, and you're basically converting to an extra cap. Then the next case on the one-eyed patient with the brunescent lens, we had maybe a half dozen smaller fragments, but they're going to drop. So there, it's hard to even get them out through a manual method, and phaco works well there in conjunction with the IOL scaffold. So those are sort of two complete opposite. I suppose there's things in between where you have to use your judgment, but the size of the nucleus, the size of the defect, often makes the difference. So I showed a bunch of cases where I couldn't really see the posterior capsule, but I could tell from the way the eye behaved, the sudden deepening of the chamber, the excessive mobility of the nucleus. You know, normally if you push the nucleus to the side, it sort of rebounds back to the center. But if you push it to the side and it stays there, you get a zonular dialysis, just like an IOL, you know, is decentering. So in those cases, no, you don't know what your anatomy is. Let's get the nucleus out. Then there are other cases where I showed 2 cases where I just had fragments left. You can kind of tell where the anatomy is. And in the first case, I was positive my CCC was intact, but in the last case, I wasn't. So there I used the IOL scaffold, and I tried to show 2 situations. One where I knew the rexus was intact. Okay, that works beautifully. You put the 3-piece in the sulcus. In the second case, if you're not sure, I kind of kept one haptic out. And it makes it a little bit more clumsy, but I just didn't want to risk having the lens now tipping and sinking. And now I have an IOL on the retina at the same time. So I appreciate the question, and hopefully that clarifies a little bit of my thinking.
So one quick comment from my
Thank
side.
you, Dr.
In such
Chang.
condition,
Yes.
in such condition, go for the manual SICS if we have pseudo exfoliating with the hard luminescent cataract. Thank you. Thank you so very much.
That
Yeah,
brings
that's a
us to
good
the end of a
point.
wonderful session.
Yeah, that was a good point, and that's you know, in the very first section where I talked about converting, I kind of showed both, and it's just really whatever the surgeon's comfortable with. You know, in the United States, nobody does any kind of extra cap, let alone SICS. So I know your audience is really proficient often at SICS.
All the way from
Thank
India.
you all.
Good technique.
Yes, it is. It brings us to the end of a wonderful masterclass on posterior capsular management in the presence of dehiscence. We really thank Dr. Dave for taking time out from his busy schedule on the weekend. It was amazing, and I'm sure we'll keep coming back to this webinar again and again to learn. I would just like to ask for some closing comments from Dr. Chang, and then we'll call it a day.
Well, I certainly appreciate again the chance to give such a long a lecture here, and I think the main goal I think today is to understand, do what you're comfortable with, but these are some ideas that in the proper setting are worth trying. I will emphasize again, do think about what you would want as the patient in these situations. It's probably the last thing you're thinking about, but if you do that, and you can be, then you can really be honest with the patient. And this is what I was thinking, because this is what, and that the answer might be, I just stopped and closed up, because that would be what I would have wanted in that situation. And that's why I referred you. And no one will fault you. You know, how can you fault someone that says that? So don't try to be a hero when you're not prepared to do that. You don't, you know, you're not doing the patient a favor there.
Thank you.
Absolutely.
Thank you all. Thank you to the panelists. Thank you, Dr. Chang, again. Thank you to the coordinators. And thank you to the audience for sitting through this wonderful masterclass.
And thank you, Rishi.
Thank you,
Good night
everyone.
and good morning to Dr. David Chang.